Welcome and thank you again. This is Sight and Sound Bites webinar series brought to you by the Eye and Ear Foundation. And we've been doing this bi-weekly series since the April of 2020. And the focus of this series is to highlight the research at the University of Pittsburgh School of Medicine in the two departments of ophthalmology and otolaryngology. I'm Lawton Snyder. I'm the CEO of the Eye and Ear Foundation. The Eye and Ear Foundation supports research to advance care for vision, hearing, balance, which you'll hear about today, voice, and cancers of the head and neck at the two world-renowned departments of ophthalmology and otolaryngology at the University of Pittsburgh. The funds we provide through the foundation to support research are really only made possible because of philanthropic support. Some of the things you'll hear about today actually were initiated with some of that support. So we thank everybody who's supported the Eye and Ear Foundation and also appreciate anybody who wants to find out how they can support the foundation. Some housekeeping rules related to this webinar. This is a Zoom product. You recognize it. It's just like when you're Zooming with your friends and family at home or at work. But it's a webinar, so we can do things a little differently. We do disable chat for this. So what you can do though is use the Q&A function, which we encourage you to use to ask questions. You can use questions and ask questions anytime during the program. We'll save those to the end and read them. If you don't know where the Q&A bubble is, it's usually at the bottom of your screen, and you highlight where it says Q&A and click in. Please refrain from asking personal health questions that wouldn't be of interest to the whole group, but we'll try to answer everybody's question, even if it's even offline or off the webinar later. We will send a survey out tomorrow. Please fill out the survey and let us know what you think of today's program. We use that for providing programs in the future. And you'll be added to our email list to receive future webinar information. To introduce today's speaker, our Distinguished Service Professor and Chairman, Dr. Jonas Johnson, Chairman of the Department of Otolaryngology and the Eugene N. Myers Endowed Chair at the University of Pittsburgh School of Medicine. Dr. Johnson.
So thank you, Lonnie, and good afternoon, everyone. Welcome to our webinar. I'm very proud today to be able to introduce to you Dr. Susan Whitney. Dr. Whitney is a physical therapist. She's a professor in the School of Health and Rehabilitative Sciences, and she's also a professor in the Department of Otolaryngology. Dr. Whitney is internationally renowned for her expertise in the management of patients with difficulty with balance and dizziness. So I think we're all looking forward to hearing her comments today. Dr. Whitney, thank you.
Thank you very much, Dr. Johnson. I want to say that the physical therapy program is the #1 PT ranked school in the United States too. So we've got a high ranking, and we actually have 4 physical therapists on our faculty, all with PhDs who have an interest in balance and vestibular disorders. So we are quite a team here. I present information today, but it's really a team effort in terms of what's new in balance and dizziness, both within UPMC and Pitt. And this is the dizziness part over here with the little cow. And here at the upper right is the concept of balance, because some people have balance problems, some people have dizziness problems, and some actually have both. And we need to learn to treat everybody differently, because everybody comes with their own set of symptoms and problems that we need to try and see if we can help fix. So what are the issues related to balance and dizziness? What's the big deal? One of the biggest deals is people fall down. And when you fall down, you can break things. So we want to make sure that people who have balance and dizziness problems don't fall down. We know that the prevalence of falling is actually much higher in people with dizziness problems. And there's been some work done through the National Institute of Health and by Yuri Agarwal, actually from, who's speaking actually at Eye and Ear next week for us. But we know that people fall down when they're dizzy. And that, I know you say, well, that's intuitive. That happens all the time. But up until about 20 years ago, that wasn't in fact a fact. That was what people believed, but there really wasn't data. And we've contributed to that. Other people around the world have, we meaning those of us here at Ioneer, and also folks, for example, Susan Herdman at Emory, et cetera. So we know people fall. We know that people's quality of life isn't as good when they have balance problems or dizziness. There's social isolation. We've done some work, did some work with some colleagues in the UK, where we looked at using something called cognitive behavioral therapy, really trying to get into how people think and change how they think to try and decrease their falls risk, because we know that it creates social isolation. People become afraid to leave the house. And we know when people don't leave the house, they get weaker. And then there's also this fear of being dizzy. So I'm not going to do this again because it might make me dizzy. And I've seen many people who have that concern. And part of my job is to try and decrease that fear so people can live their lives better and enjoy things. And there's also an association with sadness and being anxious with having a balance and dizziness problem. We know that this can happen. It doesn't happen to everybody, but it certainly is a problem when it happens if it's you. So what are we doing about all these problems? So one of the things I'm going to talk about is telehealth. We've all talked about telehealth and learned about it, most of us over the last year. And I'm going to talk a little bit about telehealth and rehabilitation. I'm going to talk to you about a big problem to people who have it, which is called visual vertigo. I'll talk about how we're starting to use apps that might be able to be used in the home for rehabilitation. I'll talk about some of my artificial intelligence work that I'm doing with a startup company. Some new walking tests that we've developed here at the University of Pittsburgh and are using. I'm going to talk to you a little bit about something called directed energy exposure and treatment that I've gotten invested in over the last year or 2 years, and some of the consensus documents, they're called systematic reviews and clinical practice guidelines that we've been working on here at UPMC and the University of Pittsburgh to improve care of persons living with balance and dizziness problems, and just stuff about the exercise prescription. So I prescribe exercise. Dr. Johnson prescribes medicine, right? Or he does surgery. But what we're trying to do is perfect the exercise prescription, and I'll talk a little bit about that. So telehealth is something that all of us have probably experienced over the last year. And with telehealth, one of the things I'm trying to figure out is what is safe to do and what isn't safe to do. So when you think about telehealth and you're talking to your doctor, they may prescribe a medicine. I might prescribe an exercise, right? That's much more likely that something that I would do. And what's safe to do and what isn't safe for people. So what we've done is we've created a survey for physical therapists, and we have 265 people respond. I'm starting to analyze the data. And what we're going to try to do is figure out what are safe things that you can have a patient do at home and what isn't. And also, what are the diagnoses that are optimally treated in the home versus ones that maybe really need to be seen face-to-face because it may be not safe to do when I'm sitting here and you're falling at home. I can't exactly catch you. And that's what we're trying to figure out rather than can you do it, because we know it can be done. We've all done it over the last year, but we're trying to change the bars so that instead of everybody thinking they can treat anybody with a balance or vestibular disorder or inner ear disorder, what we're trying to figure out is what are the safe conditions that you can treat and really help people. Another big problem in the world is something called visual vertigo. And this is a problem that not all people with balance and dizziness problems experience. But when they see very visually complex scenes, it can make them feel very dizzy and be disoriented, and it can really make it hard for people to live a normal life. One of the things that my friend Dr. Dannenbaum, Elizabeth Dannenbaum from Montreal came up with was a scale that helps you figure out if someone has this problem. And the scale is in front of you. It's called the Visual Vertigo Analog Scale. And what we know is that if you were On the left is the happy face, meaning you don't have that problem, which is watching traffic at a busy intersection. And over here is a sad, dizzy face on the right. So we have people kind of check how they feel on this scale. And what we've learned is that people who check over on this side a lot are going to be a challenge to treat. They're not your typical person. So in the sense that they've got this visual vertigo. So if you treat them and don't consider visual vertigo when you treat them, you're not going to do a very good job managing that person. So what this scale does is gives you a good idea that they've got the problem. And what I wanted to show you here, this is 250 people that have answered this scale, this visual vertigo analog scale. And what we're trying to do is figure out, should we treat people differently based on their diagnosis? And I know this is a very busy scale, but this is the total score from 0 to 100 here on the left side. And on the bottom are words that you might not understand, but these are people's diagnoses. So if you've ever had a diagnosis of a vestibular disorder, you might actually fit in one of these categories. What it tries to show you is that we don't treat everybody the same. So if you come into the clinic and you have a diagnosis, the words are bilateral vestibulopathy, which means both ears have inner ear damage, all right? The likelihood of you having this visual vertigo is very low, but look at all these other diagnoses. See the little lines here in the middle? That's like the medium score for each of these groups. And you can see that if you have the diagnosis of vestibular neuritis, that you might actually have this problem, right? Now, some don't, but if you don't use that scale, you don't know. And what it really shows me is that each diagnostic group really should be treated a little differently related to this visual vertigo. And it also tells me that regardless of diagnosis, some of these folks, everybody's going to have a little bit of this. So it's a fairly common problem in people who show up in the clinic that I see. And we have to start to treat people differently based on that. So what we did, Dr. Furman and I and Dr. Hoppus and other colleagues, Dr. Hoppus is a former PhD student who's now the chair of the U.S. Army Baylor program down in San Antonio. What we said was, can we make it better and shorter? So Dr. Furman and I came up with more questions than what Dr. Dannenbaum came up with. And we added a couple questions, and we actually found that the 3 that Dr. Furman and I added were very good questions. So we took 3 from Dr. Dannenbaum's scale and 3 from our Pittsburgh version, came up with the 6-item version. Now, instead of asking them 10 questions, we have 6 questions that I think are extremely powerful, and hopefully we'll get this paper published soon. So part of what our work is to decrease burden on patients. So when someone comes into the clinic, we don't want to ask you 80 questions if we can do it in 2 or 3. And that's important because your time is valuable. I wanted to show you some of the science that we've done that I thought at least you might be interested in. And it looks kind of silly here, right? This head over here has all these little buttons on it. And that's what we do is we actually put these little, looks like little buttons, and we put them on your head. And what these buttons do, we put them in very specific spots so we can look at how much blood is moving in your brain. And it doesn't hurt or anything, right? So it's infrared, and we're looking to see what the blood flow is underneath these little buttons, all right? And what we did in our study here at Eye and Ear, and if you're really sensitive to visual motion, please close your eyes for a minute, because this scene on the right, I'm gonna move, all right? So if motion bothers you, close your eyes, I'll tell you when I'm done. So what we did was we moved that visual scene, those of you who can tolerate looking at this, and this is in the first floor here being done at Eye and Ear, and I'm going to stop it so I don't make anybody ill. And what we did was we took people who were really visually sensitive and people who weren't visually sensitive, and we wanted to see what happened in their brain. So this picture here that I'm pointing to is somebody's brain. And what we're trying to do is figure out if the blood flow changes. And what I expected, and I think what the rest of the team expected, was that people's blood flow would like super increase with folks who the scene on the right there bothered them. And what we found was the blood flow decreased. It didn't increase. And in people who didn't have an inner ear problem and have this visual vertigo, their blood flow actually increased. So it was an opposite reaction than what we expected. So what we're trying to do is find out what's actually happening in people's heads so that we can better design treatments to help them. Now, one of the devices that we're going to use this FNIRS with is this Vertigo device. And this is a recent acquisition through the Eye and Ear Foundation that we were able to get this. And this is Dr. Sparto here, who's one of our physical therapist colleagues. And he's he's standing there, but he's actually moving himself through the grocery store. And this device, just so you can see what it can do, my PhD student here is on the right here in the lab, and she's flying the plane. So there's a plane right there. And with her feet, she's moving that plane, and she's not doing a great job because she's going to crash into the water here in a second. But you get the idea that it's a really sophisticated device, and it can measure your forces under your feet, and we can get a really good idea of what your balance is like in this device. So we've got some amazing equipment here at Eye and Ear to test different things. So one of the things that I'm working on right now is a publication with 3 or 4 other colleagues from around the United States to look at what's in the literature related to visually induced dizziness. And a systematic review is a word that means that we're looking at all the data that's out there that looks solid, and we're trying to find out what it means so that we can give this information to clinicians to make better judgments when they see patients. So we're working on a systematic review, and we're also education leaders here at Eye and Ear within UPMC, and also at the University of Pittsburgh. Dr. Furman is on the what's called the Barone Society Consensus Document Committee. What that group does is pulls together a multidisciplinary group from around the world, and they write these consensus documents so that we're all talking the same language. So the people in Germany, the people in the Western United States, the people in South America, we're all using the same criteria for diagnosis and also for management. And this is helping improve care around the world. So he's one of the key members there of the Consensus Document Committee. And one of the things that I'm doing with Dr. Holmberg from Utah is, as part of this group, the Barone Society is trying to figure out what education people around the world have to treat people with balance and inner ear problems well. And part of that, so neurologists are looking at this, the ear, nose, and throat doctors or otolaryngologists are looking at it. There's a group of audiologists that are contributing to this paper, and Dr. Holmberg and I are the physical therapists contributing to this paper about rehabilitation. So what we're trying to do is figure out what is it that people need to teach, or what are the skills that people have to know to be outstanding clinicians in this area. And that's been a fun project that we're working on together right now. We're also working on, and I'm the head author of this, a vestibular rehabilitation consensus document for the Barone Society. So I've gotten about 8 different people from around the world to help write this document so that there will be a written document about what's the best knowledge out there related to vestibular rehabilitation, and it'll come out of the Barone Society. We're also through Eye and Ear and through Pitt, we're also working on trying to educate some of the best vestibular physical therapists. So we've come up with a program called the Advanced Vestibular Physical Therapist Certification Program. And we're starting it in August. And what we're going to try and do is get some of the best neurologists, ear, nose, and throat, otolaryngologists, physicians, PTs in the world to educate people. And we just put the notes out, or the word out, and we've got about 25 people interested in this program. It'll be mostly virtual, and there'll be some hands-on information too on the last weekend that we do it. But what we're trying to do is up the game and give people outstanding clinicians to treat them when they go to get care. We're doing some things related to technology, and I want to share with you something that the Department of Defense has supported with work that I'm doing, and also with Dr. Klatt. And there's a project called Vestaid, and I want to show this little movie to you. It has a bit of a lead in, so please don't think that your screen has frozen. And it runs 2 minutes, I think, exactly. And I want to show you what we're working on with eye and facial recognition software, so that we can
Patients of vestibular or post-concussion therapy frequently complain of vertigo, gaze instability, motion intolerance, and other symptoms consistent with peripheral or central vestibular pathology. Home exercise programs are an integral part of vestibular rehabilitation to promote symptom improvement in patients. A major component of these exercises is the adaptation of the vestibulo-ocular reflex and habituation training. Presently, there is no way to track if patients do the home exercise program or if they do the exercises correctly. In partnership with the U.S. Army Medical Research Program and Material Command, Intelligent Automation Inc. has developed Vestaid, a mobile application designed to provide feedback to the physical therapist and patient about their performance. Used at home or in the clinic, physical therapists can easily adapt the exercise program to meet the needs of the patient. Short video files teach patients how to perform their exercises. These movies can be reviewed at any time to help patients who are having difficulty performing their prescription. Using head and eye motion capture, the physical therapist is provided with precise information about the patient's gaze targeting, head speed compliance, and a recording of their performance. Before and after the exercise, the patient provides symptom ratings to help gauge exercise changes. A gamified reward system has been developed to incentivize patients to adhere to their prescription and improve exercise compliance. For more information about Vestaid, contact Dr. Susan Whitney or Dr. Brooke Klatt.
So this has been, this has been probably the most fun project I've been on in my career. I'm working with all of these bioengineers and computer scientists, and their job is to do this work for the Department of Defense. And they actually do what I tell them to do. So because most of the time when it's been a Pitt project, people have 15 other projects to do. So it's been a real joy, and the patients that have looked at this have liked it. So this is just to show you some of the easy exercises that we chose for a study that we recently completed. We're in the process of writing it up, and hopefully it'll be accepted within the next 6 to 8 months. That's our hope. And I wanted to show you, so that actually appears on an iPad, could appear on a telephone also. And what it does is it tells me whether you're doing the exercise properly. So if you get in the green, you did it. If you're in the yellow, probably did it a little bit too slow. And red means you stopped or you couldn't continue. And it gives very specific input so that I can make a better decision and hopefully progress your exercises quicker. So if, for example, I were to look at this, and I could do it virtually, if I were to look at this and this whole bucket here would be green and this one would be green, that means that 100% of the time you kept your eyes on the target and your head moved at the right speed. It means it's too easy. So you don't have to wait until you'd see me again. I could actually progress your exercise via telephone and say, hey, Joe, or hey, Sue, you need to move your head faster. This exercise is too easy. Or we could go, we could go up here and I could change the background and make it harder for you because maybe the background was too easy. So it's really an exciting effort that I think hopefully it'll work and people will use it, and they're using it actually, where is it? I think at Walter Reed. In the DC area. And what we did too as part of the study that Brooke Klatt led was we got 10 people who had inner ear problems, and we asked them if they liked it. And if you can see the numbers about strongly agree and agree, they're over to the right. So we asked them if it was okay, did it seem to work for them? And the perception of the people who used it was very positive. One of the things that I want to tell you too that we're writing up, and I was going to show you some data, but I didn't want to show too much before we released the publication. But I actually took the data from the patients, the 10 patients, and I asked physical therapists, 20 of them around the country, to tell me what they would do in terms of exercise prescription with it. So here's the data. How are you going to use it? I asked people with less than 5 years of experience. There were 6 of them. I took some people with 6 to 19 years of experience. There were 8 of them, and 6 persons who had over 20 years of experience with working with people with balance and dizziness problems. And what I found was that consistently, the experienced physical therapists made the same choice, regardless of whether I showed them the videos or the paper cases, but the inexperienced physical therapists did not. They made very different decisions, and they didn't have the breadth and depth of knowledge, obviously, that the higher level experienced people did. So the lesson to me now is that across the country and world, we need to teach people better decision making so that people can be regressed more quickly and get better faster. So all the patients and the physical therapists had positive feedback. Nobody had a problem with doing the exercises. Adverse events means nobody got sick or couldn't complete the problem or the experience. And there is a difference in decision making in people who are experienced versus not. So what we have to do is figure out, how do we get people who have less experience to think like these people who are highly experienced physical therapists? We're also, you're hearing in the world a lot about artificial intelligence, and we're actually doing a project with the Department of Defense about artificial intelligence to try and help make exercise decisions. So there's a project that I'm working with where they're trying to put my brain in terms of exercise prescription into a computer, so that in the military, if somebody comes in, they may not get to see a physical therapist very early because they don't have enough of them with experience with balance and dizziness problems. And so we're trying to have a computer actually basically give exercises. If we put in the right information and the machine can think, and I can tell it to think like me, then the machine can at least get the person started on an exercise program until they get a chance to see a real physical therapist. So that's an exciting project that we're doing for the Department of Defense. We also do some work. I'm very interested in test development. So one of the more recent things that we've developed with Dr. Grove at the University of Madison, Wisconsin, is a very simple thing. Years ago, here at Eye and Ear, we developed a test called the Functional Gait Assessment. And Dr. Risley was the author of that paper. We actually collected data down in the hallway, down in the entranceway, to have a big open space when she was here doing her PhD. Part of that test includes walking with eyes open and walking with eyes closed. So with Dr. Grove, what we did was we looked at that time that it took people to walk a certain distance with eyes open and a certain distance with eyes closed. And what we found was that if it takes you longer than 3 seconds or greater than 8 seconds, depending on what it is for the screening, we called it the test is actually called the gait, well, it doesn't matter what's called, but anyway, that's the concept. What we found was that it was sensitive at identifying people with dizziness problems 98% of the time, and it identified people who are healthy 72% of the time. So this is a pretty easy test to do. Anybody could do it, and the paper, I think, has been accepted, but I don't think it's out in the literature just yet. We're also working with people around the world and around the US. So one of the projects that we actually worked on yesterday or 2 days ago with our friends from Antwerp is a project to further develop something called the Vestibular Activity Avoidance Instrument. There's an instrument, paper test that people do for back pain that can prognosticate whether you're going to be easy to get better, medium to get better, kind of you might need a little bit more work, and then harder to get better. And what we wanted to do was develop a test that could identify what kind of care people needed. So when people get the right care at the right time, they get better faster. So that's our passion here. What we're trying to do is we've collected 400 people here at Eye and Ear. We've got another, I think 40 that we've collected more recently for this particular test because we're trying to make the test shorter. And Luc Verriek and his colleagues at three different institutions in Belgium are collecting the same data. And what we're trying to figure out is, can we prognosticate who's going to get better faster? And if we can identify people that need additional care initially, we can get that fast to those people. And then I think we can prevent a lot of secondary things that can happen as a result of them bringing other things to the situation that may make it harder for them to get better. So we're very excited about that and are working really hard. And Dr. Dunlap is leading us on those efforts. With directed energy, I wanted to talk a little bit about that. So directed energy is something that you might have heard of recently with the Department of State. They came out with some information with the Department of State in December, actually, of this year. I got into this partially because of Dr. Balaban's interest in this. He published one of the first papers about this, who's on the faculty here at Eye and Ear within UPMC. And it has to do with some people, primarily Department of State employees in Cuba and in China. And you might have seen this on 60 Minutes, right? This directed energy thing. So we have recently published 2 papers about directed energy. We have one currently being revised and one submitted. And the reason I got into it is because the Department of State actually asked me to come and testify in front of a big panel for the National Academy of Sciences in Washington, D.C. And then I had someone who had this problem, one of the State Department employees, contact me, and I'm in the process of writing up his case. But the whole concept is that this is a new way that people may potentially have a war injury, this directed energy, and they appear like they've had a concussion, which is why they called me to actually testify in front of them. And I actually reviewed the document prior to it being published. It was a great honor to be involved in this. We're also doing some things that some of you might be really interested in, and that's the use of cannabis or marijuana, medical marijuana, in persons with dizziness. So Dr. Balaban and I from UPMC here and the Eye and Ear Institute are looking at all the literature with some students at the university or the U.S. Army Baylor down in San Antonio, to see what, does this work? Is there any literature about this, to try and help people living with dizziness? Because we get questions all the time about, hey, can I just try some medical cannabis? Will that help my dizziness? And it does, I think in Pennsylvania at least, it does meet the criteria, but we don't really know what's the optimal dose. And that's part of what we're looking at with the systematic review. One of the big things that we're doing, we got over $1 million to look at from the Department of Defense. And this is primarily Dr. Sparto and Contos's work that I'm on that grant also, to look at how big the dose and how intense the exercise should be for people after a concussion with some of these dizziness exercises that we give them. And again, we're trying to figure out what's the best dose. How do we get people back to work faster? And that's what the military is most concerned about. And I want to talk a little bit about the research and the clinical balance team, because I don't work alone. So Dr. Furman is our leader of our team. He's actually upstairs seeing patients right now. I saw some just a few minutes ago before I came down here. And so he has gotten this whole group together with the support of the chair, Dr. Johnson. We've got Pat Sparto and Mark Redfern are both biomedical engineers. Dr. Sparto is also a physical therapist, and Dr. Redfern in the past was an orthotist prosthetist for a while before he became a biomedical engineer. So both of them are really good at knowing how to talk to people and knowing what kind of problems persons with balance and vestibular disorders have. We have some great people on faculty here who study how the brain and inner ear work. So Bill Yates and Carrie Balaban are experts in how the brain work. They're both anatomists and physiologists of the vestibular system. And our newest physical therapist faculty members are Doctors Dunlap and Klatt, who are joining us. They're both former PhD students here that work with us, and we have worked with an army of PhD students here, both physical therapists and also engineers, to try and improve care for people living with balance and dizziness problems. So our team is all about trying to improve care for people living with inner ear and balance problems. And this was an honor to present today to you. I hope that I at least kind of tweaked your interest a little bit in some of the cool things that we've been working on here within the Eye and Ear building to improve care. So thank you, Lonnie. I think you had some questions or
Yes,
whatever.
Dr. Whitney, thank you so much. That was fantastic. Of course, I've gotten to hear you talk before, so I kind of knew what we were in for, but I think our audience would agree. And I'm seeing already a lot of questions, but this is a pretty significant problem, and certainly everybody that we know that's gone through these issues, whether they are for a short period of time or a long period of time, it really impacts your life. So it's just very grateful to see so much going on. So for our audience, please go ahead and just type in your questions. We have a few. Remember, down at the bottom, you can click on Q&A and then type your question, and we'll get to them right now. So first is something we were talking about earlier before the program. Can you talk about the Epley technique and how it helps people with BPPV?
Yeah.
And I guess maybe tell us what the Epley technique is for those who don't know us.
Sure. So people can have loose crystal. I'm sorry I didn't bring my model. I have some great models I could have shown you. But we all have crystals in our ear, but they can end up in the wrong place. And when they do, people can fall down, people can spin when they get up out of bed or when they bend over. It's extremely common. And I think in the German epidemiological study, they said about 3% they thought 3% of the German population had BPPV, these loose crystals. So the primary, you talk about the Epley is the go-to maneuver for the most common problem that you have, which is when it gets stuck in the back loop in the inner ear. Your inner ear is actually not this part. This is called the pinna, this piece out here. It's actually deep inside the head. All right, where these canals live, where the crystals live. Well, the crystals shouldn't be in the canal, that's the problem. So they get stuck in this canal, and then they cause people to spin, right? And when people spin, it's not pleasant. Some people get sick. A lot of people spin, but as you increase in age, you're actually less likely to spin. We see people then just say they feel funny, they feel lightheaded. And there's a paper that's actually supported what I always call as a Whitneyism. Sue Whitney says so. So just because Sue Whitney says so, it's not a fact, but it's really nice years later to actually see a paper that says that Whitney's right. And that when people get in there, especially late 70s, 80s, 90s, sometimes they don't spin anymore. They just feel funny or feel off. And what we do is just like when you have those games where you tilt the board to get the ball in the hole, basically what we do is we tilt the person's head relative to gravity. We tilt the head in the right position so we can move the crystals back in the right place. And it's extremely common. We see it very frequently. And just to add to that, the number one reason why people see a primary care doctor over the age of 70 is because of dizziness. That's the number one cause of going to see a doctor. And often it can be, obviously it can be because your medicine is off. If you have high blood pressure, that's probably the number one reason. But these loose crystals are pretty close to second or third. It's extremely common.
Wow. I've certainly known a lot of people myself who've dealt with that. So where does anxiety fit into the mix with balance issues? For example, could anxiety about going down an escalator cause dizziness rather than it being a balance issue?
The answer to that is yes. So anxiety can cause people to be dizzy. People who get panic attacks get one of the symptoms that some people have is dizziness. But just because you have anxiety doesn't necessarily mean you get dizzy. It does make it a little bit more challenging if you have pre-existing anxiety and get a dizziness problem or an inner ear problem. It makes it a little harder to get better, but it doesn't mean you can't get better.
Interesting. So this question is interesting as well. What is it called, or what causes this if you bend over and come up and keep going backward and fall backwards without being dizzy or realizing you're falling backwards? Is it part of the vestibular system or balance? I hope I described that right for those who put the question in.
Yeah, it could be loose crystals. It could be an inner ear problem, or it can also be a blood pressure problem.
Interesting.
So you can get lightheaded and dizzy with a change in blood pressure. If I put some young people, especially young people who are very thin, and I lay them on the ground and I tell them to get up quickly, some of them will feel lightheaded and dizzy. And that's because their blood pressure dropped. So it can actually be caused by many things.
More so low blood pressure than high. Okay.
Yeah, it's usually low, less likely to be high blood pressure. Yes.
So how informed are PCPs on the work in the Balance Center? From this question, it seems like that many people or many PCPs, aren't referring or refer for traditional care. Is that what you find, or do you think the Balance Center is well known, at least around here? I think it is, but
yeah. It certainly is here. What if Dr. Furman were here? What he would say is that the pattern of care has changed over the last 20 years. When he and I first started working together, which was 30 years ago, what would happen is he sent me all the patients. So they would come and see Dr. Furman, who's a neurologist who specializes in inner ear problems, and then they would come to see me if they were dizzy. What's happening now, especially since what Dr. Furman and I have worked really hard on, and so have the Centers for Rehab Services physical therapists, their head, which is Kathy Brandfast, is that we've tried to develop a core group of about 35 or 40 physical therapists who are really, really good at managing balance problems. What's happened then, Lonnie, is that the pattern of care has changed. So now what happens is a lot of the primary care physicians will send them to an outlying center. So maybe they live in Latrobe, so they'll go to the center there, and the physical therapist will examine them and say, oh, this doesn't fit a pattern. They need to see Dr. Furman. So what's happening is that the physical therapists are now sending the patients to see Dr. Furman instead of Dr. Furman sending them to them. So what we're doing is we're screening out a lot of people that can just be managed locally. The primary care physician may or may not know what they have, but if they saw me in the North Hills, for example, Pittsburgh, I could figure out, hey, this is somebody I can manage very easily. It's loose crystals. This is an easy one. But if I see something that looks unusual, that's when I might say, I'd call your doctor and say, hey, are you willing to send the person to see Dr. Furman, because this is an unusual pattern of dizziness or an unusual eye movement. And what he's telling me is that his referrals have absolutely flipped. They're coming in from the local physical therapist instead of the primary care physician.
That is interesting. Well, I guess that's also a credit to the education of the physical therapist, as you described. So have you found links between dizziness and migraines?
Huge. There's a huge link between dizziness and migraines. Huge link. There's a really cool paper, and Dr. Furman and I talked about this interesting paper recently, because we wanted to do it here but couldn't get the money from the National Institute of Health to do it, but they did it in Australia. They actually took people who had dizziness and they weren't exactly sure what it was, and some of them had what's called vestibular migraine. So you can have dizziness from headaches, all right? But you can also have dizziness without the headache, which sounds really, really weird. But sometimes vestibular migraine, they don't have headaches with it. And what they did was they put on these little goggles. So if you can imagine, you're sitting here, kind of like what you're having your cell phone. They had this special thing that they could put over their eyes when they were really dizzy. And they actually captured vestibular migraines in their homes. And it's so cool. And it's really helpful because vestibular migraine can look an awful lot like Meniere's disease. And they're trying to figure out how to capture out what the real problem is the person experiences. So there's really some cool work being done like that.
Wow, yeah, that's very, very cool. So how do you distinguish Meniere's disease versus positional vertigo for someone with tinnitus and hearing loss?
Okay, with ringing in the ears and hearing loss, the big identifier, and that's why you need to see a good ear, nose, and throat doctor for this, is the hearing test.
Okay.
What you're looking for is, it's called a low frequency hearing loss. So Lonnie, you and I guarantee we have some high frequency hearing loss because, we're over 40, right?
Right.
So when you're over 40, your hearing loss is at a specific frequency, okay, like a pitch, a sound. But with persons with Meniere's disease, they have a classic low frequency hearing loss. And so their hearing may be really good, and then it drops and in a different pattern than what you would see with somebody who has hearing loss from hearing sounds over their lifetime. And that's one of the best indicators, but it's really hard to make the diagnosis of Meniere's disease. The criteria that the Academy of Head and Neck Surgery have come up with are very specific. So they kind of talk about possible Meniere's, probable, and definitive Meniere's disease. And you have to, it's really hard to meet those criteria for definitive Meniere's. And it may take years till your doctor can say, I know absolutely this is Meniere's disease. So it's a big problem.
Okay, well, thank you. So just for the audience's sake, we're getting a lot of questions. I'm going to, an awful lot. This is great, but there are a few here that I will probably answer off of the webinar, just so you know, so don't be offended if I miss your question. We will get to them. So have you seen, somebody asked earlier about the migraines, have you seen improvement in dizziness with some of the things which we heard about today in terms of treatments for migraine related dizziness?
Yes. So when people have like vestibular migraine, there's specific criteria. Remember I talked about the Barone Society has rules now for the diagnosis. So now the whole world is trying to follow the rules for what vestibular migraine is, which is very helpful. So if you get that diagnosis from a good doctor, you know that you really have the problem. The best treatment, and there are several recent reviews that kind of guide care, suggest that medicine is very helpful and also physical therapy. Those in combination I have found to be extremely helpful. Doing one alone doesn't seem to work quite as well. There aren't large randomized trials to support what I just said, though, to be honest. There are several randomized trials, but not a whole lot of data, which is really sad because there are so many people that have this vestibular migraine. But it's a matter of getting the money to support that kind of research. And Dr. Furman and I tried for years to actually get money to support this concept of looking at vestibular migraine, but we weren't successful because the Deafness Institute through the NIH didn't want to pay for that at the time. Now, they may have changed their mind, because I can remember years ago, I actually went out to Vancouver to talk at the University of British Columbia, and the ENT doctors there, they didn't believe that vestibular migraine even existed. And that was probably 20 years ago. So even 20 years ago, people didn't believe that that existed. So those people living with vestibular migraine, it's been really hard because the science isn't there yet to really help you guys, but we're learning a lot more about it.
Interesting. So is tinnitus related to dizziness or vertigo?
Sometimes.
Okay.
So is tinnitus related to vertigo and dizziness? Sometimes. Not all people who have dizziness and or spinning, that's what I mean by vertigo, have tinnitus. And if when somebody has tinnitus and it's a big problem, I obviously refer them to a good ear, nose, and throat doctor. And the audiology department here, at least led by Dr. Palmer, they have an awesome program for persons living with tinnitus, which is that we say ringing, but it can be awful noises. It's not, it can be chirps, it can be trains coming through your head.
Yep.
Tinnitus is a terrible problem.
Yeah, and for those who are suffering with that, of course, it is Dr. Whitney mentioned, Dr. Palmer is a great resource, but we do have a webinar on some of the work that we have on there. You can find that on our website, and you'll find out about the research that we're trying to do to solve that problem as well.
Mm-hmm.
So this is kind of a myriad of questions here, but do you understand, as far as vertigo and dizziness and treatment, have you found that dizziness can be seasonal?
Yes, at least we have some good evidence that loose crystals are seasonal. We talked about the benign parasympathetic positional vertigo. My buddy Zuma Maya, Dr. Zuma Maya, is from South America, and he's looked at it in the Southern Hemisphere. And Dr. Balo, who actually was educated here at UPMC in the medical school, is a world leader in California, and he looked at it in Southern California. And if you look at it, the data is exactly opposite. So in the months where you get lots of sun and vitamin D, you're less likely to have BPPV, loose crystals. And it's the same, it's reversed in the Southern Hemisphere because the light and day are, the days are different. If you go south, it's light, and north, it's dark, right? So it's actually flipped. It's a fascinating piece of work these two have done.
So this question's tied to this, or not, well, the same person asked, do you think problems with body core strength is relevant in dizziness?
Don't know. Nobody's investigated that related to body core strength, but having good body core strength is good for anybody. Mm-hmm. So it's certainly something that has value. I don't know. Well, if you have a significant balance problem, yes. I would definitely say yes, having a strong core is really essential. But probably even more than that, I'd say you gotta have good feet.
Okay.
And I know it sounds silly, but it's not at all. There's wonderful data by Dr. Lord's group out of Australia. He's out of Sydney, mm-hmm. where he's done, hopefully you can see my hand because I can't see my hand, but with you have these muscles in your toes. All right. So imagine my fingers or my toes. You need to have good, strong toe grippers to improve your balance, right? And we know that if people's toes don't work very well, they don't bend, they're really stiff, and they're not strong, your balance is off. And that's what Dr. Lord has shown. And so the person that I saw this morning is a very active guy who's mid-50s, and his balance is off. And one of the things we're working on is getting, I call them your toe grippers. So what people need to do is really make sure their toe grippers are strong. And if you start to lose your balance, Lonnie, and you start to go, if you grip with your toes into the earth, you actually, your balance is better. And so you've got to make sure that you've got good toe strength. So core strength obviously is important. I agree with whoever asked the question. But an add-on to that, a group of muscles that people don't think about as much are your toe benders, your toe flexors, we call them. Those are really critical for balance.
Wow. So the next question actually is, I guess for me, it says, will your presentation be available online so I can pass it on to a neighbor who can benefit from it? And the answer is yes. This will be recorded, so we'll send it actually out to everybody that's on today or signed up today, and then you can pass it to your friend. Are there any new approaches to treating dizziness from superior canal dehiscence syndrome, if I said that right?
Well, yes, you did. And it's a relatively rare condition, thank goodness. It causes balance problems and can cause dizziness. And there's things that happen related to sound with people with this rare condition that don't normally happen to other folks. Surgery is still probably the #1 thing that people do for superior canal dehiscence. What happens is that if this is a loop, say this is the loop of your semicircular canal, your loop, What happens is that there instead of bone being on top of it, what happens is the bone deteriorates, and then it kind of it hits a spot that it shouldn't in your head, right? And what they do is they go in and they try and repair that hole, essentially. And they think that you're probably born with it. We now know, just so you know, for the person that asked it, we have 3 loops and 3 semicircular canals in our ears. We now know that it can occur in any of the 3. And we have 3 on this side and 3 on this side, right? So Lloyd Minor came up with the first surgical procedure when he was at Hopkins before he left to go to Stanford. And people do superior canal dehiscence at eye and ear, the surgery, but there's at least some evidence that exercise in conjunction with the surgery may have some value, but I haven't seen anything more than that. Because I'm not an expert in superior canal dehiscence, because most of the time they're seen by the surgeons to try and repair that problem. And some people don't have the operation. You have to decide. Not everybody says it's worth trying to fix it. Depends on how bad the symptoms are.
So this question, what can be done to maintain vestibular health as you get older? I think this is what we all want to know, right?
Oh, move. So movement is
Exercise.
key for life. So that's really, really, really critical. And we know that we lose hair cells in our inner ears and stuff like that. But truly, walking, moving, doing something that you love to do, but not sitting. So sitting isn't going to improve your vestibular health, but we do believe that movement will.
So can anyone see Dr. Whitney's PT group? I guess that's just the question. Can anybody see Dr. Whitney's PT group?
Sure, you can come in anytime. All you have to do is call us, on the 4th floor here at Eye and Ear. We see folks, and if we're too far for you, we have people. I have a network of folks that we actually refer people to, so we know that you get good care locally too.
Okay. So please explain the difference between vertigo and dizziness, and explain how balance is related.
Okay, so you have to be careful when you use those words with a doctor because they mean different things. And if you use the wrong word, you get sent to the wrong place. This is the truth. Because I've heard people say, I have vertigo, and I'll say, well, what does that mean to you? And they'll say, well, I wobble when I walk. Well, that's a totally different thing than the world going like this. So vertigo means this, okay? I wrote a paper years ago for a former faculty member here, Dr. Kammerer, about dizziness. And I actually gave a list of words that people use for dizziness, and it was about 25 different words long of what dizziness meant to them. That I'd heard from patients over the years. So dizziness is a nondescript word. It's a very personalized thing. And it doesn't really tell me a whole lot except something's off and you're not right. This tells me a whole lot and puts me in different categories in terms of diagnoses, because not too many people say they actually spin. But again, you have to use the right words. And when people have dizziness, their balance is often off too, but not necessarily. So I've seen people who are dizzy and their balance is pretty good. And I've seen people who have balance problems and aren't dizzy at all. So again, you have to use the right words when you go see a doctor.
Interesting. Thank you. That's the best explanation I've ever heard for that. So are there research studies that someone can participate in, and how do you find out about those and sign up for those?
There are, and I don't have, there's a site on the University of Pittsburgh, and there may be one on UPMC too, where we have studies that we're recruiting for through the Institutional Review Board. And if I'd been prepared, maybe we can add that later, but I know that there is a site for volunteers, and we're always looking for good people.
Okay, great. How much does acoustic neuroma affect balance?
Depends on the size. So depends on the size. Actually, the larger it gets, the less dizzy people get, because there's usually a compression on the inner ear nerve and they can actually lose hearing and also lose their balance. So if you have an acoustic neuroma, that's a tumor, okay,
Mhm.
that's in the inner ear area, all right? And it causes pressure. And if it's really small, people can be off balance and really dizzy. But as it gets bigger and bigger, sometimes there eventually is, it kind of can crush the inner ear nerve. And when that happens, you don't feel quite as off because the other ear can kind of take over. Because usually one ear will work well and the other ear may be damaged by the tumor. But people can live pretty well for a long time with a small acoustic schwannoma.
And exercise, the other things help with that. That's another question, actually. Okay.
Absolutely. Exercise definitely helps with folks. And there's really good data that the surgeons are aware of now that if you do exercise before you have the operation, if you're going to have this taken out, or you can do radiosurgery, they can actually kind of radiate the thing. But exercise before actually results in much better outcomes. And that's from some work out of Sweden.
All right. Well, we are at the end of the hour, but there's just a couple here. Is double vision related to vestibular vertigo? Double vision.
Not usually. Double vision is not usually related.
And the last question, is there an available online program to practice the exercises for dizziness?
There are some apps that are available that you could try. It's just I'd probably get a little bit of professional help before I try them so you don't make yourself sick.
Okay. Well, thank you. We certainly have gotten, we got through a lot of questions. We had a lot of participation today. Thank you all, everybody in the audience. As I mentioned, there are a few questions that we will send emails to respond to as opposed to answering on the webinar. But thank you. This obviously is an important topic by the number of people that we had on today. And I think we need to talk more about balance. There's many areas that we can cover here. So thank you so much. Always a pleasure. And for everybody out there, have a great day.
Yes. Thank you very much.
Take care.